Assalamu alaikum. Good morning, ladies and gentlemen. Today's first workshop is about the neonatal Resuscitation program, and it will be presented to you by me, Dr. Rehab, and my members, Dr. Ammar, Mohammed, Dr. Georg, and Dr. John Golden. He will present it virtually. Now, before we know why, how to use most of the newborns, most of them will start program breathing on their own, but not all of them. Now, according to research, 85% of the newborns within the first 10 seconds of life begin breathing on their own. However, 10% will begin breathing in response to drying and stimulation. And to successfully transition, approximately 5% might need positive pressure ventilation, 2% might need intubation, and about 1 or 2 newborns per 1,000 livers might need just conditions and use of emergency medication. So what I'm trying to say is that not everybody thinks and start to transition from his or her own. He or she needs our help, and we don't know which one of them needs our help. There is one before each birth. Now, again, how to resuscitate, we should have an idea about how the transition is going to be. The intrauterine physiology of the cardiorespiratory system and the extrauterine one as well. Now, as can we see here, for the intrauterine one, for the fetus, the blood is coming from the intestine and carrying oxygen. That oxygen is transported via the umbilical. The inferior vena cava, then it will be carried to the right side of the heart. That oxygenated blood will be carried to the right side of the heart, and because in the intrauterine heart, the lungs are filled with fluid, and the pulmonary blood are supported. Not all of that blood will be shunted to the lungs. Actually, little amount of it. It will be shunted, that oxygenated blood, to the left side of the heart via the patent foramen ovary and the patent ductus arteriosus. Then it will be supported to the rest of the body, most importantly, the heart and the brain. Now, this is the, in the still life. About the transitional circulation path or the neonatal resuscitation. Now, after birth, and with the first exercise and the breathe, the lungs of the newborn will be filled with air. That air will help to relax the pulmonary blood vessels. At the same time, we suppose that the absorption is cancelled. There is no presence anymore to get that oxygen, and here the lungs should take its role in the process of ventilation. So the air in the lungs will help to dilate or let's say relax the pulmonary blood vessels, and of course the oxygen and the carbon dioxide will be delivered to the alveoli, then by expiration outside. The oxygenated blood here will be carried to the heart via the pulmonary veins. Then it will spread to the rest of the body. Now, that's a transition has been 2 minutes of life, but at full or complete, the completion of that transition might take longer time. For example, for the oxygen saturation to reach an FPL of 10 or 90% or it takes 10 minutes. For the absorption of the fluid in the baby line, it takes 2 hours, and for a complete relaxation of the pulmonary blood vessel, it might take even several months. So the question is, what would happen if that normal transition for a reason or another is interrupted? Okay, thank you. Oxygen will be low, of course. Acid will start to accumulate, and the blood vessels and the intestine, kidney, for example, will concentrate in an attempt to pump more blood to the brain and to the heart, the most important organ. However, this is a temporary survival, will not continue, and if we don't intervene, the heart will start to fail, and there will be multiple organ damage. So that abnormal transition will be reflected in the form of signs and symptoms that we should be aware of or to not only aware to error them. For example, there will be an abnormal breathing, irregular breathing, resuscitation breathing, there might be bradycardia or tachycardia, and pale skin or cyanosis with low oxygen saturation, low muscle tone, and low blood pressure. Because the deterioration kind of rapidly, and because all of the processes will take place, of course, at the first minute of life, and the importance of immediate the first minute of life is called the golden minute, which is calculated from the birth of the last part of the life of the newborn outside the mother's body. So if we didn't make an appropriate resuscitation in a timely manner, this will be reflected in a bad way on the long term on the health of that newborn. That is why the first minute of life is very important. Now, this is the algorithm put by the American Academy of Pediatrics for the insulin. As you can see, it's made of 5 minutes. First, we go through them one by one. We should keep in mind that resuscitation focuses on ventilation. The problem is in breathing, not in the heart, even if the heart was the baby presented with a bradycardia. It is about ventilation. So having resuscitation skills is not enough. Why? Because mostly the resuscitation is more than one person. Normally there's one fixed number, 2, 3, 4, 5 according to the situation. If those members, no matter they are well skilled, if they don't organize their work, this will be reflected badly on the newborn. This might cause some delays. That is why there should be what is called teamwork, communication skills. They are very important. Each member should know the scenario that the baby will be upcoming with, according to the counseling and treatment counseling. They should maintain a professional behavior. They should assign a leader. Each member should know his or her task so that their work should be organized. Not only this, even before the birth of the newborn, we should have what is called the pre-gestation briefing. Again, that is to delegate the task so that each person will know his or her role and to have a good coordination of their work. After the session is done, there should be what's called a team debriefing. The aim of that is to improve the skills of the members to know in which parts or areas of the education they were wrong or didn't perform effectively and in which areas they were discharged, so that in the future they can avoid the mistakes and have more experience. Again, this is not enough. What to mean by being ready? Add to all of this is checking the equipment that we need for resuscitation. This is a matter of minutes and seconds. Cannot help any delay. For example, if I needed an envelope and something already, where should I find it? No, check before the birth. And it should be disinfected, sterile, and ready and inside. So we would need the equipment to watch the newborn, to clear the airway, to auscultate, to ventilate, to oxygenate, to medicate, even to intubate. About 4 and that's why we should have a checklist before every birth of each baby. And later on, we will show you the equipment that we need during resuscitation. So now we didn't resuscitate, just being ready. We should have the antenatal counseling, briefing, check. Then comes the birth. Now, about the antenatal counseling, it is very important before each birth to ask the obstetrician 4 important questions. These are: what is the gestation age of the newborn? Is the amniotic fluid clear or not? Are there any additional risk factors? And we should understand about the umbilical process. Because according to these information already, the answer to these 4 questions, we are anticipating a certain scenario accordingly to put us down for the resuscitation. Now, after this, we should make, we are ready after doing all of that. After that, we should make a quick assessment for 3 questions by observing the newborn. It is whether the newborn is term or not, is that newborn trying to breathe or not, and about the muscle tone as well. Now, a good muscle tone as well is universal flexion by flexing the upper and lower limbs towards the torso. So, the scenarios, the resuscitation will be according to the answer of these questions. Now, for the fibers, 10 newborns, here we can give them the routine care. In this case, we will be making about something to start the drying, warming, peptide stimulation of the fire, changing the upper to suction the airway if needed. If needed, it is not done routinely. Now, for the preterm newborn, non-vibrant newborn, they could present signs of stem or apnea. Here, we should immediately cut the umbilical cord, transfer the baby to the resuscitation, and start the steps of for the resuscitation. The warming, the drying, positioning the airway, suctioning if needed, and peptide stimulation, which is normal, and know how to do them appropriately before jumping to the next step if we need it. About warming, of course, we are going to put the newborn in a position on the first heated warmer, and start the drying using towel that are fresh, dry, and warm. Once the towel is wet, we should replace it by another one, because if you put it on the baby's body, this will cause hypothermia, and with its detrimental effects. Our aim is to keep the body temperature of that newborn in the range of 36.5 to 37.5 degrees Celsius. An exception for this step is in case that the newborn is presented with birth asphyxia. Exactly. Here we are not going to make a warming step because a passive cooling as a step towards therapeutic hypothermia. Okay, about the dryness and I mentioned. And again, an exception for this is for preterm newborns with other registration is less than 2 weeks. Here we are not going to perform a thorough dryness, and we are keeping in a plastic bag to reduce the excessive heat loss or evaporated heat loss. Sorry. About the stimulation, peptide stimulation, please, it is to stimulate breathing, not the crying, because sometimes I see the opposite arrogance. The baby is crying, but she is instead than he or she should be breathing, instead than he should be crying. And she started standing, and by birth, the stimulation, this is wrong. Peptide stimulation is to stimulate breathing. This is done in the appropriate way by rubbing the bag of the newborn or setting the sole of the feet. Shaking is wrong the other way of upside down, holding the baby and stacking the bag. Again, this is harmful and wrong and should be avoided. Now, about positioning the head to open the upper airway. While we are putting the baby on the resuscitation in the supine position, the head should be up, so the eyes should be facing the ceiling, let's say, or in another one, let's say, keep the head and then in the neutral position or slightly extend to the back, so that the chin and the nose will be at the same level. This one as splitting the morning air position, it will help open the upper airway and making the respiration easier. Now, again, about the suctioning, if needed, it is not done routinely. For vibers and the newborn, they don't need suction. And for those who cannot breathe, or those who have their sufficient oxygen in their airway, or let's say we are going to use the PPD positive ventilation, here we need to suction the airway. Again, not vibers. We start suctioning the oral cavity, then the nasal cavity, not to suction deep. You might estimate on many with stimulation. This is because that's the target once. So we are going just to suction the oral cavity and nasal cavity, and again, not more than 5 centimeters for the oral cavity, not more than 1 centimeters for the nasal cavity. Now, what about the umbilical cord management? At the beginning, during the antenatal counseling, I answered 4 questions. One of them is the umbilical cord management. And to plan, have the delayed clamping and the early clamping. Now, delayed clamping is the clamping of the umbilical 30 to 60 seconds. For the vibers, newborns, vibers, preterm newborns, the aim of that is to make more blood to come to the newborn so that the newborns, it would help to have a better hemodynamic stability. Of course, during that time of delay, the 36 minutes we are trying the baby, warming, making the tactile sleep, and all the steps that I mentioned. Of course, with observing the newborn. And during that time, we are keeping the baby on the mother's chest or abdomen as a source of heat, of course. About the early or the immediate examining, this is done in any situation that affects the flow of the blood and the umbilical cord to be newborn, like being born with severe vaginal bleeding, other cause of placenta, having the abortion placenta, for example, abnormal placentation, or the newborn was cardiac or IUGR, or if there is multiple gestation. Here now, we should immediately expand the umbilical cord and start the resuscitation. All of that was the first step of neonatal resuscitation. After that, we should observe the baby to see the result. So either the baby will be coming, breathing well, and everything is fine. In this situation, we will keep the baby with his mom for further evaluation and routine care. Or either the baby is born and after this steps is breathing okay, but that breathing is unable to breathing, or maybe the baby is still diagnosed despite the breathing. Here we should consider breathing and higher concentration using the pulse oximeter and even consider using CPAP. Or after all of these is because the baby is not responding well, still gasping or active or having a saturated minutes. Here we should proceed into the next step of resuscitation using the PCV, powder pressure ventilation. And this will be presented by my colleague, Dr. Ammar Saadi, the pathologist from Iran. That's okay. Thank you for your time.